Shubham will be sharing screen of yeah, kind of it.
Let me little quiz for all our participants. So our participants presently are at 24, but we are not worried about numbers because in this format, write your name is the correct. But here are the questions to begin with. You can start reading them out.
So great. Thank you, Shubham. Thank you, Dr. Shona. Thank you, Dr. Geeta. And this is the first question for the case. So question number 1. As per the CREATE X study in the triple negative breast cancer population, post neoadjuvant chemotherapy, the addition of adjuvant capecitabine was associated with, and the choices are 1, a 40 to 50% reduction in risk of recurrence and death, 2, 45% reduction in risk of recurrence but no impact on overall survival, 3, 20 to 30% reduction in risk of recurrence and death, and 4, impact on reduction in risk of recurrence and death was not statistically significant.
You need to read that question twice actually to understand it. Sorry.
Okay. So
but
once
no,
again,
just the question will do. I'm sure everyone.
The options are. So next question
is for us.
Yeah. So reported BRCA1/2 positivity rate in triple negative breast cancer is, and we are looking at India specific answer, 45 to 50. So, and those are the options on. So as per the available data, platinums when added to neoadjuvant chemotherapy in locally advanced breast cancer, that is triple negative, lead to an improvement in option number 1, progression-free survival, option number 2, overall survival, option number 3, pathological complete responses, and option number 4, both pathological complete responses and progression-free survival. So again, the addition of platinum to leads. Okay, so these are now going to be a couple of tricky questions, and I would agree that these are medical oncology oriented. So, pembrolizumab in combination with chemotherapy in metastatic triple negative breast cancer led to 1, a statistically significant improved progression-free survival and overall survival in the group that had PD-L1 grade of CPS greater than 10. Option number 2, a statistically improved progression-free survival in the group that had PD-L1 CPS greater than 10. Option number 3, a statistically significant improved progression-free survival and overall survival in the group that had PD-L1 CPS greater than 1. And option number 4, a statistically significant improved PFS and OS in the intent to treat population. So this is pembrolizumab in combination to chemotherapy in metastatic Tnbc, and the options for improvement are as a view. So this is the last question. Sacituzumab govitecan at ZIY is an antibody drug conjugate that is 1, being investigated in locally advanced triple negative breast cancers with a PD-L1 CPS greater than 1, is already FDA approved in pre-treated metastatic triple negative breast cancer, 3, associated with improved pathological complete response rates in neoadjuvant setting, or 4, FDA approved in first-line metastatic triple negative breast cancer.
Search on this because I remind everybody and from. So Nag, you've been at.
Good evening. Any assure you, that I learn every time I listen to her, and I think the clarity of her thought is something that the budding medical oncologist should really pick up. She is the director of oncology in Sahyadri Group of would not and really
Geeta, because there is so much data that is coming in every day as we speak. So I thought I would just do an overview of triple negative breast cancer. Where do we stand right now, and where are we headed in the future? Okay. The outline of the talk, a brief introduction, biology and molecular heterogeneity of triple negative breast cancer. We'll discuss a few emerging biomarkers, talk about early Tnbc and mainly neoadjuvant strategies, and finally end with metastatic triple negatives and talk a little bit about PARP inhibitors, immunotherapy, antibody drug conjugates, and what is beyond. So if we look at the distribution of the different subtypes that prevail in India versus the West, you can see very clearly that triple negative makes up a large proportion of our breast cancers, 29.8% in this study from TMH versus 10 to 15% for breast cancers in the West. The epidemiology of triple negative sparked a lot of interest way back about 15 years ago, and the Carolina breast cancer study was one of the first population-based case control studies to come out, and they showed that there was an increased incidence of triple negatives in the African American women. These women were young, 50% were young, under the age of 50. The risk factors were slightly different from the luminal cancers. So patients, in fact, women with more than or equal to 3 children, and those that had a first birth below 26 years of age, those which had a high parity and no breastfeeding, and finally a waist-hip ratio of 2.3, that is mainly central obesity, were markedly involved in a high risk for developing triple negative, versus breastfeeding was in fact very protective. And this has been borne out in several epidemiological studies since then. The natural history is something you are all aware of. You see it in the clinic. The recurrence risk is highest in the first 3 to 4 years, and that's why chemo is more effective in this subtype than in the luminal subtype, which can even relapse 10 and 20 years later. There is a sharp decline after that, but really the first 2-3 years are when you lose the most patients in the clinic. What about the staging? If you look at the 8th edition of the AGCC, patients with triple negative, regardless of their grade, have a survival comparable to patients with disease 1 stage higher. So if you have a stage 2A, she has a prognosis of a stage 3A. And that's why we are so keen to get in effective adjuvant chemotherapy, even in smaller node negative tumors. Coming to subtyping, there's been so much and so many classifications. So this was a very elegant paper by Pratt in 2013, and there was a molecular characterization of basal and non-basal-like. And what they did first in about 1,000 patients, they first split them by clinical status, and then they split them by subtype status. So if you look at the triple negative group here, you can see that 22% almost of these are not basal-like. They are either HER2 enriched, or they are luminal, or they are normal-like. And on the contrary, if you look at the other half, which are basal-like, 32% of these basal-like are not triple negative. They are hormone receptor positive or HER2 positive. So there's a lot of heterogeneity even at the molecular level. If you look, then Lehman et al. Came up with a classification in 2011, and he divided triple negatives into 6 molecular subtypes. Remember that this is all transcriptomic, this is all gene expressions, and the subtypes independently predicted PAT-CR, but not overall or distant metastasis-free survival. Another elegant thing that this group did was they developed cell lines according to these 6 different subtypes, and they showed that each of these cell lines had varying drug sensitivity. They further revised their classification in 2016 into 4 different subtypes. So you had BL1, BL2, M, and LAR. BL1 being the basal-like one, which involves the DNA damage response pathway, show extremely high proliferation, and this is the subtype we associate with response to platinum and PARPs. Then you have the basal-like 2, which express all the growth factor receptor pathways and EGFR. And these are the true basals. Then you have the mesenchymal subtype characterized by epithelial mesenchymal transition, the EMT, you get stem cellness, you get PIK3CA mutations, they make up metaplastic cancers, and they are responsive to mTOR inhibitors. And finally, the luminal androgen receptor-like, they're more like ER-positive breast cancer than like triple negative. They're linked to apocrine tumors, and they have a lot of PIK3CA mutations. So what this classification did was it told us about the differences in presentation, prognosis, and response to treatment. And then of course, Bernstein's group from Harvard came up with another classification in 2015. Here they had the LAR, the MES, which is mesenchymal, and they had two subtypes, the basal-like immune activated, which include all the immune infiltrates and are very, very treatment and chemosensitive and sensitive to immunotherapies, and the basal-like immune suppressed. There has been an Asian study as well, and I would like to mention that, which has classified 465 primary triple negatives into 4 subtypes. And what they found is, so this is the first time East Asian population was classified molecularly, triple negatives, and they showed that this proportion of patients had a higher luminal androgen receptor and an increased frequency of PIK3 mutations. The basal-like group also forms the cluster 10 of the Metabric Consortium, which is divided in breast cancer into 10 gene expression clusters. So what are the emerging biomarkers, and what would we like to do in the clinic when such patients come to us? And do we need anything more than ER, PR, HER2, and Ki67? So you know that triple negatives are a heterogeneous disease. I've already showed you the differences in molecular subtypes, but even morphologically, and this is something our pathologist will report to us in the clinic. So it ranges right from the adenoid cystic, which have a good prognosis, apocrine medullary, to the invasive lobular high-grade, the high-grade metaplastics, and the IDC high-grades, which portend a very poor prognosis. Let's look at BRCA and markers for homologous recombination deficiency. These are up and coming, and they have a great implication for PARP inhibitor and such therapies. So funnily enough, the BRCA gene was identified way back in 1990 by Mary King's group. And it was first called BRCA not because of breast cancer-related gene, but it was a short form for Berkeley, California. And then it was later changed to represent breast cancer susceptibility. It was subsequently cloned in 1994 by Myriad. Around the same time, the BRCA2 gene was discovered by a group working in London, in UK. So BRCA mutations, the majority of hereditary type of cancers will show a triple negative phenotype, but most triple negatives are non-hereditary, and they will make up, BRCA mutations can be seen in about 10 to 15% of all triple negative cancers. BRCA mutations are relevant for response to platinums as well, and there is a phenomenon that you should be aware of called BRCAness. This is a sporadic tumor which has a phenotype like a BRCA-positive mutated tumor, so it shows you the same kind of high proliferation, genomic instability, p53 mutation, and it can also show a good response to PARP inhibitors and platinum therapy. Another thing that is coming up is loss of RAD51. This is nothing but an effector molecule involved in repair of DNA damage. And it is part of the whole BRCA1 and BRCA2 circuit. And now we're able to pick up loss of this by IHC and thereby tell that the patient has a defective DNA damage repair mechanism in their tumor. So there are lots of little things that are coming up that can be useful to us in the clinic. Now, very clearly, and this is something taking you back to your basics. So although BRCA, the loss of BRCA1 and BRCA2 is a autosomal dominant condition, at the molecular level, it behaves like an autosomal recessive condition. So you are born with one defective gene, and the second hit occurs at the level of the somatic. It's a somatic mutation, which can either be a chromosomal loss, a mitotic recombination, or a deletion. So this leads to complete loss of BRCA, and what is later I'm going to explain is synthetic lethality. So there are lots of paths to defective DNA repair in breast cancer. You have the hereditary mutations of BRCA and PALB2, which make up 5%. You have mutations only in the cancer, the somatic BRCA, which make up another 3%, so that's 8%. Then you get another lot of epigenetic mutations, which make up another 5%, so about 15%. And if you look at the unknown genes which are involved in homologous recombination repair, that takes us to about 18% of deficient HR repair in all of triple negative, mainly triple negative disease. And this is again back to basics with the pathway. I would like you to ignore the red dot and the red arrow. So this is the PARP1 enzyme. PARP1 enzyme is really, really important. It is important for DNA repair, but it is important for repair of single strand breaks. So when there is a single strand break, the PARP1 enzyme, which is really very sticky, it comes and it gets stuck here and it creates pyrrolation. So by transfer of this NAD molecule, it creates these huge branches of amino acids, and it recruits all the effectors, BRCA2 being one of them, Fanconi's gene being one of them, RAD51, RAD52 being others, and it leads to the repair of the single strand. Now, when you introduce a PARP inhibitor, obviously the PARP1 has got attached to the single strand break, but it can't separate from it. It also learns to separate from it once the single strand repair is started off by a process known as autopyrrolation. So this PARP inhibitor does not let this PARP enzyme move, and this process is known as PARP trapping. And the more PARP trapping there is, the more potent the PARP inhibitor. Right? And that is something important clinically for you to remember. So now, single strand breaks are repaired by very faulty mechanisms called basic excision repair. So this is also not happening once the PARP inhibitor is stuck to the PARP, not allowing it to move, not allowing it to recruit all the proteins. So the single strand break then deteriorates into a double strand break. So you get this huge break over here. And if your cell is proficient, that means BRCA, which is involved in homologous recombination repair, which is specific for double strand breaks, it's perfectly done and your cell survives the insult. But what if the cell is HRR deficient or has a BRCA mutation? So what happens is, here is your complex, here is your PARP inhibitor, here is your PARP1 enzyme with all the other molecules. And this is the direction in which the replication fork is traveling when there is a replication. So what happens is it then hits a snag with this whole complex here, it gets stalled, and then it literally breaks off and the cell dies off. So this process is known as synthetic lethality. Now, I'm not going to go into each one of these, but these are the kind of biomarkers that you could have, and if you had all the facilities and platforms available for measuring homologous recombination deficiency. So your germline is what we're doing regularly. Then you can do somatic BRCA and other mutations. You can do RNA and protein expression signatures. You can do something as an HRD score or a HR detect, which is like an HRD score, which involves taking DNA from the tumor, doing a whole exome or genome sequencing, and looking for phenotypic scars. So that's what it really looks at. So what is the scar? So basically, when a tumor loses its ability to repair DNA, so due to either epigenetic mutation or a somatic mutation or a germline mutation, it kind of adopts some other mechanism. And each time it tries to repair, it leaves a genomic scar. And you actually can measure these scars by different computational methods. And one of these is known as the HRD score. So here you can see from Miranda Telly's group that the minute you have a nice high HRD score, that is also related to an increased PAT-CR, telling you that these are the patients who are exquisitely sensitive to chemotherapy and platinum. Another way of measuring this genomic scar is a commercial assay called HR Detect, and that can predict BRCA deficiency with a 98% sensitivity using a cutoff of 70%. So more than 70% indicates that there is a deficiency there. We switch gears now to PD-L1. Everybody's talking about immunotherapy, and we breast cancer people were really getting left behind because we didn't have stuff to show like lung cancer and bladder cancer and melanomas and other urothelial tumors, etc. So we have caught up to some extent, but not fully. So PD-L1 is important for breast cancer as well. And the problem is, how do you measure PD-L1 and how do you know that the immunotherapy is going to work? So there are different drugs, and each of these has a different companion diagnostic. And the one that we're most interested in is the ICA, the immune cell score A, which is more than or equal to 1% for the use of atezolizumab, which has been already approved, FDA approved, and available now in India for the first-line treatment of metastatic triple-negative breast cancer. How does this compare with the other scores? So 1% of ICA is equivalent to a 21 score of CPS, 10% of IC, and 10% of TPS. So each is measuring using a different formula of measuring the immune positive T cells, the immune cells, and either doing a percentage or not. And you have different platforms. For example, for Atezo, you have the Ventana platform, the SP142, and then you have the 2263 DACO platform for the CPS. So there are different platforms also available, and they go along with the antibody that one prescribes. There are different roles for immune biomarkers for PD-L1, and I'd like you to remember this. So PD-L1 is important in both early and metastatic triple-negative breast cancer. But in early breast cancer, it's only predictive for neoadjuvant response. It is not specific for immunotherapy. Whereas for metastatic triple-negative, it is predictive for response to immunotherapy. So that is important to remember. And this is data from the Impassion 130 study for Atezo. And you can see that 40% of patients had more than 1% of were PD-L1 positive, 27% low, that is 1 to 5%, and 14% high, more than 5%, and the rest were negative. The PD-L1 status also differed between the primary and metastatic disease, and you can see here these are the differences. And unusually, you can see peculiarly that in the liver, the expression of PD-L1 was really low as compared to the other metastatic sites. Now, what does this mean? And is there a difference of magnitude of benefit with higher PD-L1 expression? So this is not so in the Impassion 130. Whether you have 1 to 5% or you have 5% or more, your patients will derive an equal benefit. But unlike another study, which I will show you, which is the 355, which was recently presented at ASCO by Cortez and his group, a CPS or a combined positive score of 10 or better was much better than CPS 1 and led to greater benefit. Okay, so looking at this is one of the older studies where they looked at CPS, I think, for monotherapy. And here again, you can see as far as CPS goes, yes, there is a differential benefit. And once you cross 20, you get the best benefit in terms of progression-free and overall survival. TILs are a matter of great interest. They've been around forever, but we've just noticed their importance. They're very easy to quantify. So if your pathologist is not doing them in the core biopsy, please ask them, because it gives you a sense of prognosis. It may also help you to predict a PCR in your patient. So here you can see in this Denkert study, if you look at the overall PATH CR rate, it's pretty low. But if you look at the group with increased TILs, more than 10%, they had a PCR rate of 30%, and when the TIL went up even higher to what is called the lymphocyte predominant breast cancer, and I'll be defining that in a minute, the PCR rate was as high as 41%. And this is a very elegant study of the 6 neoadjuvant trials from the German group, and you can see here that PATH-CR rate is clearly related to the percentage of TILs. You can get a low, intermediate, and high, and this is how it's defined. This is the LPBC, or the lymphocyte predominant breast cancer group, and they show the highest PATH-CR rate of almost 50%. Shirin Loy's group also showed that for every 10% increase in TILs, there was actually a 13% risk reduction of recurrence. So they very well correlate with event-free survival as well. And this is another study from Loy and her group where they looked at 5 adjuvant clinical trials where they treated the patients with anthracycline and early stage Tnbc, and you could correlate an increased TIL expression in all these with improved invasive disease-free survival, distant disease-free survival, and overall survival as well. And remember, these are stromal TILs, not tumor TILs. So the quantity of TIL is important. They are prognostic in early stage TNBC and HER2 positive disease. They are predominantly activated T cells which secrete PD-1 and PD-L1. And as you go into the metastatic stages, you will certainly not find TILs because there is a concept of when the tumor is in the primary tumor or in the first line metastatic setting, the immune environment is very, very immune rich with a lot of TILs, PD-L1, PD-1, CD8-4, and is a very plastic amenable environment to immunotherapy and chemotherapy. As metastasis goes on and you go into the second and third line setting, it becomes more and more rigid and the immune infiltrate drops down drastically, and these tumors now become immunologically cold and they don't respond well to immunotherapy or even systemic treatments at all. So tumor mutational burden, which is an excellent marker for some of the other diseases, is rather disappointing for breast. As you can see, breast is not a very immunogenic tumor. Anything which has new antigens excites an immune activation. That does not happen normally in breast, except for cases of triple negative, that too, like I said, in the early sitting. But here you can see on this whole exome sequencing, there is a correlation of increased mutational burden with the triple negative subtype. At the end of discussion of markers, I would like to say that you can't just take one marker in isolation. They are all correlated. PD-L1 is correlated with TILs, is correlated with CD8 expression, and we are moving to an era where it's not going to be that one marker that's important, but a signature which is going to use a combination of these and other genes as well in order to tell us and give us better prognostic and predictive information. So coming to the clinical aspect and how do we really manage early and metastatic triple negative breasts? So this is a 42-year-old lady and she has no comorbidities. She has a large 4-centimeter lump in the right breast. She has palpable axillary nodes. Her biopsy shows poorly differentiated invasive ductal carcinoma and she has negative IHC staining for ER, PR, and HER2. She's been referred by the breast surgeon to discuss chemotherapy. The question in my mind is, yes, I think this lady is young. She has a large tumor node positive. She will benefit definitely from a good neoadjuvant regimen. Should I be adding platinum or not? And should I be aiming for a PAT-CR? So you're all aware of something known as the triple negative paradox with triple negative breast cancers. And what this means is you do get a high PAT-CR rate, no doubt. But in spite of getting a high PAT-CR rate in the range of 30%, you still have a worse prognosis in these patients. And that can be explained by this cartoon, where you can see that those that achieve PAT-CR do exceedingly well and much better than their other counterparts. But those that have a residual disease do much worse than those that have residual disease of their other luminal and counterparts. So residual disease gives you a pretty bad prognosis in this disease. Let's dig a little deeper. Is it as simplistic as PAT-CR versus no PAT-CR? And should we be looking at other indices like the RCB index? Less than PAT-CR doesn't necessarily mean a poor outcome. And this is a very elegant study which has been done, that there is a heterogeneity of less than PAT-CR also. And we've started doing RCB very, very recently in the clinic, and the pathologist is slowly getting used to it. You just need the biopsy and the pre-surgery data, and you need the tumor size, the axillary nodes, the size of the largest met, etc. And what they found in this study, it was not only the RCB 0 where there was no residual disease, but also the RCB 1s which had a comparable prognosis. So if you look here, the RCB0 has an overall 5-year relapse-free survival of 94%, and those with RCB1 have a survival RFS of 89%. And I'm comparing this to RCB2 and 3 at 5 years with RFS of 62 and 26%. So definitely, if you don't get a PAT-CR and you have minimal residual disease, you should also be a little assured. And there has been a lot of criticism about PAT-CR. It's certainly not the perfect biomarker. And this is from the Cortazar meta-analysis, which was done by the FDA. And what you can see here, and what I'd like to point out here, is that there are those that achieve PAT-CR and yet they do badly. All right, so this blue group is telling you that in spite of achieving a PAT-CR, these guys eventually die. And on the contrary, there is a group that does not achieve PAT-CR, and they continue to do well. And that is seen in this analysis and in the German meta-analysis. And now the golden question is, who are these patients? And once we know this, I think we really crack the issue of neoadjuvant chemotherapy and PAT-CR and escalation strategies and de-escalation strategies, and it will be extremely useful to have a robust biomarker in the clinic. There is a huge rationale for giving platinums, and that was my second question. Yes, I want to aim for a PAT-CR because individually that's telling me if my patient has a PAT-CR, she's going to have a favorable outcome, and it's reassuring to her, it's reassuring to me, and it's reassuring to my surgeon as well. The question is, should I give her platinums in the neoadjuvant setting or not? Or if not that, then in the adjuvant setting, should you use it at all? So we know that we talked about DNA damage, and alkylating agents in platinum salts are very damaging to the DNA, and BRCA, is important. So, and there are all these DNA damaging repair pathways which are activated in triple negative. So it can be lethal to these patients, to the tumors of these patients. So there are several randomized neoadjuvant trials investigating platinum in triple negative, and some have reported event-free survival as well. And the two that come to mind and that have been the subject of great debate is the JEPAR-6 and the Alliance study. So both had triple negative patients in the neoadjuvant setting, and both, they were slightly different in design. Both had bevacizumab as well, and the Alliance trial had a 2x2 factorial design, plus or minus carbo, plus or minus bev to the paclitaxel arm, whereas this had liposomal doxorubicin with or without platinum. All the patients got bev. The difference was that in the Alliance trial, the patients received dose dense AC as well, and this seems to have made quite a bit of impact. So if you look at the PCR, it's really very encouraging. You have a 16% improvement with the addition of platinum in JEPAR-6, a 13% improvement in PAT-CR with the addition of platinum in Alliance. But let's look at what happened to EFS. So if you look at EFS, certainly there is a good difference of almost 10% in disease-free survival in the JEPAR-6 study. This unfortunately was not seen in the Alliance study. And then, of course, everybody ran to explain why this was not so. Nevertheless, we do have two contradictory trials. So although one study has shown a benefit for PCR and event-free survival, most of the other studies have just shown an improvement in PAT-CR. And then what they did in the JEPAR-6 is because we are all convinced that carboplatin is the be-all and end-all for BRCA mutated tumors. So they looked at that germline BRCA population. It wasn't a big number, okay, and that I'll grant, but you can see that there was a benefit in the wild type. Certainly it increased the PAT-CR rate, the platinum, but the germline BRCA were already so exquisitely chemosensitive that even without platinum, they had a great PAT-CR, and adding platinum contributed more, and since they were more chemosensitive, they derived a larger benefit. So whether this was a true benefit or just a question of adding on another chemotherapeutic drug, we won't know, but we will give them the benefit of the doubt because we do know that in a few small retrospective studies of platinum and germline BRCA patients, there have been excellent complete responses and PAT-CRs as well. This question people have tried to answer again and again, and last year in SABCS, a small randomized phase 2 study was presented of preoperative cisplatinum versus AC in germline BRCA mutated patients. And then what they found, and these included ER positives and ER negatives as well. And if you look at the TNBC group, there was actually a better benefit for the AC arm, and so also with the ER/PR positive group. So this should make you think that is it the alkylating agent in the AC which is doing the job and all the DNA damage, and platinum is really not adding that much to it when you're giving, when in our sequences we're giving AC or we're comparing it with AC, or should we give either one or the other alone? And the NCCN guidelines have raised the same controversy. They've said that it remains controversial. Some studies have shown PAT-CR improvements, long-term outcomes remain unknown, and it's only for select patients. Now, the question to me would be, would I incorporate platinum in a patient, a young patient who I want a PAT-CR? So I'll tell you the situations I use it in. So usually in patients with triple negative tumors, I do start with weekly paclitaxel. And if I find after 3 or 4 weeks of paclitaxel, the patient is not getting a shrinkage the way I wanted, I will add the platinum. Or if I get a bad T3, T4 disease and I really want rapid shrinkage, that's the time I will use the combination of paclitaxel with carboplatin. Carboplatin either weekly or 3 weekly, depending on the tolerability of the patient. So again, switching gears to immunotherapy. So there's a lot of metastatic data, but is there any early data as well? Yes, there are some randomized phase 2 studies which have shown a value of neoadjuvant immune checkpoint blockers, ICBs, in this condition. And one of these is the Japan-Nivo study with durvalumab. What they did was first a run-in period in one of the arms, followed by Pacli and EC, and the other was placebo. And interestingly, if you look at the results of the study, it was the arm which had that 2-week run-in period which showed an improved PAT-CR with durvalumab, and this requires further investigation and study. Then again, the Keynote 522 study was presented by Schmidt and his colleagues at ESMO last year. And here you had newly diagnosed TNBC and you had all stages, even early stage disease. It was again here carboplatin in both arms with doxo or epi with cyclophosphamide, and pembro versus placebo, and maintenance pembrolizumab to give you about 48 weeks of treatment with pembro. And what happened clearly here is if you look at the pathological response, there was a delta of 13.6 between the pembro and the non-pembro arm. But if you look at the PD-L1 status, it didn't really matter. Both the PD-L1 negative and the PD-L1 positive derived equal benefit. Although, like I said, PD-L1 patients are definitely more chemosensitive. Anyway, their baseline is better. They respond well because they have all those TILs in their specimens. So you could use it in either. And there is another study, the Impassion 031, which will be presented very soon with neoadjuvant atezo with Pacli, and this is also a positive study for high PAT-CR. Talazoparib is also being used in the setting, and in germline BRCA mutation, this is a very provocative study by Litton's group, and in patients who had 2 months of talazoparib monotherapy, a single tablet, you had a PAT-CR of 53%. And if you counted the 0 and 1 RCB, it was 63%. And this is the first of its kind study to show a single targeted therapy achieving such a result. And we have a lot to look forward to for PARP inhibitors in the neoadjuvant setting. So when do I consider adjuvant therapy for triple negatives? All tumors who are 0.5 centimeters in size or more, any node positive tumor irrespective of size. Once the tumor crosses 1 centimeter, I prefer to give an anthrattaxine regimen. Otherwise, I will give 4 TC or 6 EC, whatever. The benefit of anthra in small tumors less than 1 centimeter, which are node negative, are modest. They are there. It's about 2.5% absolute benefit, not more than that. 2 studies looking at really small TNBCs which have been untreated have shown quite an encouraging relapse-free survival. But I would be reluctant to not treat if the tumor was between 0.5 and 1 centimeter. And as we know, dose dense chemotherapy is preferred in this group. So back to our case. So this lady had receives dose dense AC, paclitaxel. So she does not receive carboplatinum. This is followed by surgery. And the surgery reveals really very, very, I can't even say T1, let's say microscopic disease and an RCB1. What would you do next? So this is the data from the EBCT-CG group, which shows you a nice benefit, absolute reduction of 4% in recurrence and 2.8% in death with dose-dense regimens in hormone receptor early breast cancer. Now, what about maintenance strategies? So we have excellent anti-HER2 treatments. We have super hormonal therapy for all our different subtypes, but we really had nothing to offer our triple negatives, especially after finishing adjuvant treatment. So this is an older study of 2015, which looks at oral CMF or cyclomethotrexate as maintenance, and the greatest benefit was seen in the node-positive triple negative cohort. This treatment is a little toxic. It may be metronomic, but it's not without its mucositis and other problems. So then came all the data for capecitabine in early triple negative. And this was the most recent study presented at ASCO this year. This was from China. And you had women, and a lot of these women had stage 1 and stage 2 tumors. They were only 46 years old was the median age, so they were young, and they were randomized to 1 year of low-dose capecitabine maintenance continuous versus observation. And these were the study results. Nice benefit in disease-free survival of 10% and of overall survival in 5%. And even though they say the OS is not statistically significant, I like these curves. And for a difference of 5% in OS, a lot of people would also decide giving and not giving treatment. So I think that this is important and this is a significant study. And the only downside is the toxicity. You are giving the patient 1 year of hand put, you are giving leukopenia, you might have to monitor the LFTs. So it comes at a price and it needs to be discussed with your patient. In the historical context, we are all aware of the CREATE-X. The CREATE-X study showed a really good benefit in the triple negative subgroup again for both disease-free and overall survival. So there was about 20 to 30% reduction in the risk of recurrence and death in this triple negative subgroup. If you, So if you look at the GICAM study, controversially, now this is a large study, but it was actually a negative study for adjuvant capecitabine. Look at the doses that they used, but they showed a benefit for the non-basal subtype. So how do I put all this into context? So that's the CREATE-X data, that's the Chinese data, that's the GICAM data. So this is 32% of the patient population. These are all TNBCs. This is residual disease. So this is a more resistant population. This is adjuvant chemo. This is after the adjuvant chemo. See, both these studies, mainly the benefit or the group was made up of premenopausal women, and 2 studies out of 3 have shown a really remarkable and to me significant difference, both in terms of DFS and OS. And I would certainly discuss this strategy and be more inclined in my motivated and younger patients to use it. The ongoing trial, EA1131, should finally be able to answer these questions, randomizing patients between platinum and capecitabine in the adjuvant setting. So coming back to our lady, she receives 8 months of adjuvant capecitabine. She's on regular follow-up. 2 years later, she comes with a local recurrence and has lung mets, supraclavicular lymph nodes. Urine biopsy, there is recurrent triple negative. She is BRCA negative. In germline testing, what would you do next? So that is the algorithm that we have today. We do PD-L1 testing and we do it with the SP142 for the atazole. And we then decide, so about 30 to 40% of our patients are PD-L1 positive. The rest who are negative, they undergo germline, MSI, and NTRAC and other clinical trials. And I think there are a lot of first-line exciting clinical trials going on with immuno and AKT inhibitors, which are starting in India. So there is a lot to offer our patients. And in the later setting, saxituzumab, a drug that I'm really very eager to use, has shown great benefit. So pembro monotherapy has had modest responses. These are the overall responses. And but if you look, even though the PFS has not been great, it has translated into a decent 12-month overall survival with almost 40% of your patients being alive. And these are, remember, in all heavily pretreated. So earlier, when a patient metastasized in triple negative disease, your overall median survival was about 13 months, and your progression-free survival is between 3 and 4 and 5 months. So I think this is quite a good result to achieve in a previously heavily pretreated population. And the data for Atozo was very encouraging in the 1B clinical trial of 33 patients. You had super responses in first line, you had a great PFS, 8.6 months, and you had 24 months OS. So 13 months is what I've been telling you about, but this group had 24 months. And this led to further clinical trials and set the stage for Impassion 130, which I think all of us know by heart. So you're looking at locally advanced, inoperable, or metastatic Tnbc, who's had prior chemo in the adjuvant setting, include taxanes if it was 12 months earlier, a good ECOG, visceral mets allowed. These patients were unselected for PD-L1 and randomized to Atezo plus NAB versus placebo plus NAB, and the co-primary endpoints were PFS and OS. And if you looked at the intention to treat, it met its primary endpoint of PFS, which was just about modest 2 months more than the placebo group. But the real question is the overall survival. So if you look at the intention to treat group, there wasn't really much of a difference between 18 and 21 months between the two groups. But if you looked at the PD-L1 positive group, this was a pre-specified analysis. According to me, they really shouldn't have done this, but they were so intrigued by the findings that they had to declare them. And there was a 7-month OS benefit in the PD-L1 positive population. So you had patients living for 25 months. And the 355 study presented by Cortes this year at the ASCO meeting again showed that if you look at the group, which was the PD-L1 with a combined positive score more than or equal to 10, your hazard ratio for progression-free survival is 0.65, and it is 9.7 months versus 5.6 months, which is highly statistically significant and I think clinically meaningful as well. There are a lot of combinations of immunotherapy with chemo and other agents, and there's a strong rationale for that. And rather than go into it all, I've tried to put it down in a table. So this study you've got with pembro and eribulin, it has shown good, decent response rates. It's in first to third line patients. Then you've got combinations of immuno with PARP inhibitors, immuno with MEK inhibitors, and now immuno with AKT inhibitors. So let's look at one or two of these studies. So this was a very interesting study, and basically, like I told you, these are patients who have been pre-treated with up to 3 or 4 lines of chemo, and they are immunologically cold, and I've explained this. So what happens to them when you give them a PARP? You activate a pathway called the STING pathway, and it makes the tumor immunogenic, leads to interferon activation, whole lot of inflammation, and a lot of neoantigens for the tumor to respond to. And the cold tumor gets converted to a hot tumor. And that's the rationale for combining a PARP inhibitor with immunotherapy. And the efficacy in the BRCA mutated lot was a 49% clinical benefit rate, and you can see a PFF of 8.3 in tumor BRCA mutated and 6.4 when you included the ones with the homologous recombination repair mutations as well. This is again proof of concept study where you can use radiotherapy to kick off the immune effect in the tumor. So this is known as the abscopal effect, and you can induce distant tumor responses. And the hypothesis is by giving immunotherapy 3 days before or after the radiation, you will cause this abscopal effect. So this is the example of the patient is given. So this is a highly metastatic patient, and she had pembrolizumab, and few days later she received radiation to the left breast mass. And after 12 or 13 weeks, you can see that every other site had responded, including the site that was repeated. So you can, these are rare responses, but there is some thought to be given to this, that maybe combining immuno with something else, immunoplus is the order of the day. And this is the tonic trial. Again, sensitization to immunotherapy was done by a whole lot of different chemotherapies, and then followed up with radiation to modulate the response. Again, the principle converting non-inflamed to inflamed tumors. And then they found that the greatest responses were seen with when you induced with doxo or cisplatin, and this is now going into a phase 2 or being expanded to a phase 2 study. What about AKT inhibitors? So the AKT P10 PIK3CA pathway is mutated in about 10 to 20% of triple negatives, and these are some of the early phase 1 studies and the waterfall plot, which shows you a nice set of responses with AKT inhibitors. Then you have the famous Lotus randomized placebo-controlled phase 2 study, which was presented 2 years ago. And here patients were then randomized to ipatasertib, which is the AKT inhibitor, versus plus Pacli versus Pacli alone, and primary endpoint being PFS. But when they looked at PFS in the intention to treat, it wasn't so different. But when they looked at the PIK3CA AKT-P10 altered pathway, you got a difference of almost 4 months with a hazard ratio of 0.44. And this difference in the curves is what has led to the development of the phase 3 study. The trend in OS has also been seen with a benefit almost of 5 months. So this is the trial that a lot of us are going to be doing very soon. It's a phase 3. This was the 1B for the dose finding and the safety analysis. And we're doing a phase 3 of ipatasertib, atezo, Pacli. And the randomization is to ipata versus no ipata. And for all PD-L1 positive patients, they will be getting atezolizumab. So back to our patient. She receives first-line atezo with NAB. She does well, and she has an 8-month PFS. What are her next options? So are you going to give her platinum now? And I think you're fully justified. Or would you opt for eribulin? I think there is no right answer. I think both are acceptable choices. So there is data for eribulin, and I thought I would show this 301 study. Everybody is aware of the Embrace trial, but this is a very intriguing trial. Overall population did not show any benefit between eribulin and CAPE, but if you looked at the subgroup analysis, there was a 5-month improvement in overall survival of 14.4 versus 9.4 months. So this is something in a heavily pretreated population that you could be looking at. I now come to one of my last sections, which is PARP inhibitors. Now, PARP, unlike in breast, unlike ovary, has really lagged behind, and it's really a little bit of a disappointing story. But it was way back in 2005 that synthetic lethality proof of concept was demonstrated. There was a first in-human study by Fong in 2009. Then there was the disastrous iniparib trial, phase 2 being exceedingly promising and the phase 3 failing at a major session at ASCO, reason being that iniparib is not really a PARP inhibitor, and finally a breakthrough with the availability and approval of olaparib and talazoparib for HER2 negative metastatic breast cancer patients who are already also germline BRCA mutated. As I mentioned earlier, PARP trapping is important for its single agent activity, and talazo is the most potent PARP and veliparib is the weakest PARP trapper. It's important to keep in mind. It also correlates with the toxicity. So veliparib will have less hematological toxicity as compared to talazo and oral parib. And this is the trial by Tutt that set the ball rolling. And this is a nice phase 2 study in metastatic germline BRCA mutated, where he showed a 40% response rate in patients with single and it was actually a dose finding study. And once this response rate was seen, of course, the next logical step was phase 3 designs. We had 2 main agents then, and of course, since then, the Bravo study has come in with niraparib, and that has also been a positive study. So these were patients who received 2 and 3 lines of treatment, no platinum within 12 months. They had to have had amlodipine, and the comparator arm did not have platinum. All right. There were some key differences as well. So I've done something which one shouldn't do, and that is a cross-trial comparison. But I think it helps us put into context how similar these trials are. So the PFS is almost the same benefit. Hazard ratios are also almost the same. Response rates are great, 60% with a single agent PARP inhibitor. Now, we've been discussing this patient for a long time, and we said that she was PDL1 positive. Suppose she had been PDL1 negative and had a germline BRCA mutation and had relapsed 2 years after adjuvant therapy and did not have any cost constraint or money constraint. So, would you give her a platinum or would you give her PARP? Frankly speaking, I'm finding it difficult to choose. So I really want to look at the data of the sequencing, which is not completely available. So this was a very elegant study, which was quite a shocker at SABCS, presented by Andrew Tutt, where he showed in the germline BRCA mutation, single agent carboplatin outdid docetaxel, not only in terms of response rates, but also in terms of progression-free survival. Whereas in the non-germline mutated, they were roughly equivalent. He also had a subset with the HRD, and there also, again, platinum did not outdo docetaxel. So it was only in the germline group, all right? And so that is a reason, because this is a pure first-line study. There is no head-to-head comparison between platinum and PARP inhibitors, nor will there ever be, I think. The question is there data for first-line use in PARP inhibitors in such a patient? So we must remember that almost 1/3 of the patients in Olympiad and BRCA were chemo naive for metastatic disease. And it is in this group that you see a large benefit with a hazard ratio of 0.51 and a median overall survival difference as well. So this is the group that we are really looking at. And yes, so I think both would be reasonable options. So again, putting all 3 trials into context, TNT was the only first line, okay? Olympiad and BRCA were second and third line, but there were a group who were chemo naive. And remember, in both these groups of PARP inhibitor studies, there were ER positive patients as well. And that's something we always forget, is that young ER positive should also be tested for BRCA. And if you look at all 3, the efficacy is quite comparable. Response rates are great with platinum and PARP. Time to response is probably faster with chemotherapy, but then even with PARP inhibitors, you can get a response in a couple of months. Can PARP be used after platinum? So if I were to use platinum in this patient, and there is data from the Abrazo study that if she relapsed 6 months later after the platinum, okay, I have a role and I have a window to use a PARP inhibitor at this point, because platinum sensitivity is a predictor for response to PARP inhibition, but there is very little data for the reverse for platinum after PARP inhibitors. So which PARP to choose depends on the toxicity, depends on what you're comfortable with. The same with the palbo, ribo, and abema story. So anemia is really a problem, and in younger patients, in my experience of about 6-7 patients that I've treated of ovarian and now breast, I haven't really found it a huge issue. Fatigue is the main thing my patients grapple with. They get nausea, but after the first 2 months, this nausea is very easily dealt with and goes away. And alopecia is also seen, and that's something you need to warn your patients about. Extending the use of PARP data in this ASCO again. So patients with germline mutations other than BRCA, somatic mutations, somatic BRCA allowed, and this was the expanded access and use of olaparib. And you can see mainly PALB2 mutations in the germline, 82% response rates. And in the somatic BRCA, 50% response rate. So it does work across other germline mutations which are involved in DNA damage repair, and in somata BRCA as well. And this is something we'll be learning about soon. Luckily, I haven't had any resistance yet. So there are patients who get resistance to PARP inhibitors. The commonest cause, and there are about 5-6 reasons, are reversion mutations, where you get another insertion that takes place and it reverses the open reading frame back to normal. The stop codon, which happened earlier, stops happening. The BRCA starts functioning properly, and the patient now becomes resistant to the PARP inhibitor. And the last bit of my slides, I cannot not talk about this very exciting ADC. And really, if you had to ask me what is the future of medicine and cancer medicine and breast cancer and lung cancer medicine, especially breast, it would be antibody drug conjugates. So whether it's HER2 positive disease, whether it's triple negative disease, and I'm sure we'll find something for ER positives as well. This is the future, a smarter way to deliver an old cytotoxic. So the first study was a negative one. So there is a very promising one, lidaratuzumab vedotin, where you look for the LIV1 receptors, which are expressed in over 70%, single agent activity 37%. It has also graduated in I-SPY 2 as an effective agent, but the hero is really saxituzumab, which has combines with TROP2 again, which is amplified in 88% of triple negatives. The payload is SN38, which is the active medical item irinotecan, and it has a single activity in heavily pretreated patients of over 30%. So this is the drug, and the beauty it has is that it has so many chemo molecules attached to it, so many payloads attached to the linker, that what happens is when this combines with the TROP receptors, some of it goes in, but some of the payload also circulates to the neighboring cells. So there's a high drug to antibody ratio, 7.5:1. So not only does that cell get targeted, but also the neighboring tumor cells as well. So it really is a targeted chemotherapy. And this was the very, very popular and very impressive phase 2 study that Bardia presented at SAPCS, where he showed a response rate of 34%. Of course, neutropenia is something you have to deal with, but I think we've all become used to that with chemotherapy. And the best responses were seen where the IHC expression of TROP2 was in the 2+ and 3+ patients. And these patients had a PFS of 7.8 months. And these patients had received 3 or 4 lines of previous treatment for metastatic disease. It was truly a heavily pretreated population. The ASCENT trial was ongoing, and this was a phase 3 study, reasonably sized between Saxi and treatment of physician's choice. And of course, the primary endpoint is PFS. We have news in April. Immunomedics, which is the company that makes saxituzumab, has halted the study because the Independent Data Safety Monitoring Committee has seen the efficacy and is convinced and has thought it wise to stop the study prematurely. And the phase 3 trial, this was reported last month in the news, in patients who've received at least 2 prior therapies, met its primary endpoint for PFS. It has also reached its secondary endpoints of OS and ORR, and it is also the first ADC to improve outcome in relapsed or refractory metastatic triple-negative breast cancer. So we're really excited to see the final results and to have this drug available with us. This is my last slide. The androgen receptor, targeting it and the concept of targeting it has been around for a very long time, but the studies really have not taken off the way they should. We know that almost 20 to 30% of our triple negatives can have a LAR subtype, and this is the subtype, as I mentioned, behaves like ER positive disease. They have very low PAC-CR responses to chemotherapy, yet they have a better overall prognosis because they have an indolent cause. They will relapse in the lung, they will relapse in the nodes, just like hormone receptor disease. So these are all the different studies that have taken place. The clinical benefit rates have been very modest with very little PFS benefit, which is in weeks. And the most recent study combined bicalutamide and palbo, and this was presented in ASCO this year in a poster. And the study met its select subset in AR positive triple negatives. Now, the problem is also the cutoff. So, this study used more than 1%. Some studies have used 10%, but I guess anything more than 1% is okay. And they showed that 1/3 of their patients were progression free at 6 months on the combination. And now this is going to be expanded into a larger study. So, with that load of information, I shall leave you and thank you so much for your attention. I hope I haven't bored you too much. I've tried to cover the molecular classification, talk of emerging and present biomarkers, tell you that signatures for biomarkers would be far more important in the future. We've talked about various strategies in the early setting, the neoadjuvant setting, the value of PAT-CR. We've talked about metastatic triple negative and the exciting arena of immunotherapy, PARP inhibition, the combination of the two, and finally the ADC. Thank you again.
So, thank you, Dr. Shona. This was an excellent presentation, and just for the audience, when I was doing my residency, my first year DM in 2008, I think you had come down to Ahmedabad, and we were all really impressed by your clarity of thought and the amazing eloquence that you possess. And I'm sure I'm feeling that again today, and I'm sure all the audience are feeling the same.
Thank you so much.
So I think in the interest of time, I will start the Q&A session. Dr. Geeta, is that okay?
Yeah, sure. Please go ahead.
So I think we already have a question in the chat box. So Dr. Shona, this is the question. So do we get a BRCA testing for all triple negative breast cancers before starting treatment? And I think this is more from treatment perspective rather than any preventive aspect. So what's your take on this?
So my take on it is I usually refer triple negatives below 50 or 60. I use the NCCN criteria. I do like to do the BRCA testing upfront, but our Indian population is a slightly different population. They're really not interested in finding out their genetic risk. They just want to get on with the treatment. So at some point during the adjuvant treatment, I do like to do it. Or if my surgeon says if she's BRCA positive and she's an educated lady, I may offer her a bilateral mastectomy. So then you have to sit with the whole MTT and decide when you're doing it. But yes, I like to do it earlier than later. All metastatic triple negatives below 60, definitely, with the availability of PARP, with the importance of platinums and alkylating agents, with simply knowing their prognosis, because I think BRCA and breast is bad compared to BRCA and ovary, and I like to know what I'm dealing with, and I like to come in with a PARP inhibitor if they can afford it earlier on. So yeah, I would like to do it upfront, but then it's not always possible.
So I'll just take it further and say, so in your practice, for a patient with a locally advanced triple negative breast cancer,
right?
The presence or absence of BRCA is not going to influence your decision.
Not really. So usually with large LABCs, where I really want a quick response, I will add the platinum irrespective. And we showed that data, that it's really controversial data. We know it adds to the PCR, but we don't know that the tumor is just responding to another agent. All right, because sometimes you give AC to these patients and you get the most fabulous responses. So the alkylating agent and the combination is obviously doing something. So it's not only the platinum per se. But yeah, in a locally advanced large tumor, I would not wait for my BRCA results. I would probably do weekly Taxol, add platinum, or like I said, if it's a smaller tumor and I want breast conservation and not getting the reduction I want, 3-4 weeks later, or 3 weeks later, I will introduce the platinum. So this is the strategy I use.
So Dr. Shona, would you do AC followed by a Taxol and carboplatin or a cisplatin, or would you do just carboplatin and start off with the carboplatin?
So in triple negatives, what I to do, and see, both are okay. The sequence doesn't matter. All the MD Anderson data is with Paclitaxel upfront followed by anthracycline, right? So for HER2 positive and for triple negatives, I prefer to give the paclitaxel upfront. Then I have an option of adding the platinum or the anti-HER2 agent. And then I do the AC later, and then I send the patient to surgery. So this is my neoadjuvant approach.
So I've come across a couple of patients, young patients, who responded well to AC, and the moment you switch them onto your paclitaxel if it is without the carboplatin, they tend to progress, and then you don't know what to do.
My God, I haven't faced
Lavender, I mean, two of them both in their 30s, and you've had this problem. It responded exquisitely to AC, and the moment you put them on paclitaxel, and
I've had both situations where the response it doesn't progress, but it plateaus. I think that's what you're getting a shrinkage, and suddenly that shrinkage stops, and that's a little worrisome. Because in neoadjuvant, you're supposed to measure it every 2 cycles, right? And your surgeon is supposed to look at it. So very often I send it to my breast surgeon, and I have in some ER positives where we need a conservation or a shrinkage, I give the AC first, and then my surgeon will say, you give the Taxol and then send her back to me. I'm not happy. Obviously, it's a ER positive tumor. It's going to take that much more time to respond. It's not going to respond the way these tumors are going to respond. But I generally start off with taxane, and I haven't had a problem. Devdutt, what has been your experience?
Yeah, so I know the patient that Dr. Geeta is alluding to. I think we shared that patient. And while she was BRCA negative, we did add carboplatin in the taxane phase, and unfortunately there was a lot of poor tolerance, and
oh dear, yeah,
discontinued. And I think that's been one of my experiences, especially in Indian women, younger women, is that a few of them have a lot of myelosuppression when you add platinum. Yes. And I fully agree to you that a lot of studies have looked at AUC 6 every 3 weekly.
No.
You look at a weekly platinum and taxane.
And I start with a 1.5 weekly, and then I go up to a 2. But you're absolutely right, the myelosuppression, and these guys may be harboring some sort of BRCA2 dysfunction, and they crash. Even with AC, some of them crash. So, it's like you rightly said, in an older patient, I think AC Taxol is perfect, and I won't even think of a platinum. It's this really bad, large tumors that I would think of.
Your experience with, immuno in the neoadjuvant setting, any Pembro that you're using in the neoadjuvant?
I saw a patient, and she fit in the criteria, and then I said, no, this is getting ridiculous. Just for a PAT CR, query PFS benefit, why am I wasting so much money? I'll keep it for the metastatic setting. Because, see, if you use it in the neoadjuvant setting, my question is, I don't know if I can use it in the metastatic setting if she's PD-L1 positive, where it's really shown an overall survival benefit. That overall survival benefit is not seen in the neoadjuvant setting and will not be seen looking at all the data. So I would rather keep it for later. Although I must say it is tempting, but no, I will keep it for the metastatic setting. What about you, Devdutt?
So again, I agree to you. I've used atezolizumab in the metastatic setting. I have a couple who responded very well.
Very well, yeah.
Although one of them I couldn't do the SP142 because it wasn't available, and I looked at the TACO 22C3 and she was 25%.
Yeah, so and that matches with a positive Ventana. So
but the cost implication, and as you said, the data is still very early. Probably in the future, but not yet. Not yet. So the second question that we often face in our tumor board is how early in a triple negative breast cancer do you start thinking neoadjuvant chemotherapy, right? Because typically a node positive is a one where you would start thinking neoadjuvant. Similarly, for somebody who needs a breast conservation, are your criteria different for a triple negative setting as compared to an ER/PR positive or a HER2 positive?
No, not really. I think that it's a principle. So usually all my node positives who are triple negative and HER2 positive go for neoadjuvant. All right. Then, if we are sitting in Europe, then anybody with a tumor more than 1 centimeter goes, which I think is absolutely ridiculous. We've got to be a little reasonable here. So, like you said, breast conservation is a big indication, and usually in a tumor more 3 centimeters or more, that's where I would like to really give a neoadjuvant, because there should be something left, no? Sometimes what happens is you don't put your clip in time, it gets missed, then the tumor is gone. It's a nightmare after that. So I think 3 centimeters is something I'm comfortable with.
I'm glad the medical oncologist is thinking about the surgeon.
I agree because I was worried about the clips that we place. So that's what I was wondering.
No, it's damn important, because you feel happy that you can't feel, and the surgeon is then cursing you to high heaven and saying, "What the hell have you done here?" So it's a real downer when you haven't put your clips in time. So yeah.
So I think we'll take a couple of questions from the chat box. So this is a very good question. Is triple negative a contraindication for oligomets CA? So I think I'll probably paraphrase it. Is there a concept of oligometastatic breast cancer when we talk about triple negative?
Certainly, there is a concept of oligometastasis, and I'm not, honestly, possibly triple negative is possibly the only one I'm not very comfortable with, because I don't have anything to fall back on. If you have oligometastasis with the ER positive, it's easy because they're mainly bone mets. You can radiate them radically. Even if it is a HER2 positive, sometimes you may not need to even do anything to address that oligomet. It just disappears. Like you have a single liver met. I gave this lady pertuzumab, trastuzumab, and hormones because she kind of didn't want chemotherapy. She was 70 triple positive. She's gone. That single liver met has gone. Her breast lesion has gone, and she's not going to ever opt for surgery. I would have, had she been younger, considered it. But we're just going to go on with the treatment. But triple negative is one disease where I'm really weary of believing in oligometastasis, because I've had an experience where I've tried to be radical and then had brain mets coming back within 6 months. So not until we get more information on the subtype and more of the predictive markers and treatments.
I think I would agree with it. I think we've had a couple of patients as well. When they were very keen for a radical treatment. We weren't, considering the biology, and we did go ahead and I think 6 months down the line in one patient and a year down the line the other, we had a lot of metastatic disease, and at that point radical treatment certainly appeared futile. So
what do you think? Because you're the surgeon, you're going to operate the breast in that scenario. So all the studies except for that Turkish study, which again had oligomets in the bones, I think, the group that where they showed a benefit.
Yeah. So the Turkish study also.
Negative, no?
Yeah. So they were the hormone sensitive ones. The triple negatives and HER2 positives. HER2 positives possibly yes, because
now you have an armament.
But now there has been a recent update from Seema Khan on
correct.
And she said that local treatment does not add to overall survival benefits. So we have to look at it again. The only subset that I think it works is the ones who got oligometastatic bone disease with ER/PR positive, HER2 negative young patients. Otherwise, I think the experience is not that great. But triple negatives is something that you keep you stop, and it's almost as if the patient is forcing you to do it. Otherwise, triple negative is definitely off my list.
Yeah.
So the next question is: do you do androgen receptor for all TNBCs?
Well, not really, because I'm not sure of how I'm doing it and how it's being reported and what the cutoffs really are. But there have been a few cases of mine who have been metastatic TNBC, absolutely ECOG 0-1 patients, coming with a breast mass, a few nodes, bone metastasis, and I've proceeded to give them chemo simply because they are triple negative. And there's been absolutely no response, no progression for months. And then, I've thought in a couple of these patients, we've got to check the androgen receptor. They're behaving like ER positives. And sure enough, one had 90% staining, the other had 80% staining. So I put both of these, one on enzalutamide, one on bicalutamide. The one on bicalutamide progressed within 6-8 months, but the one on enzalutamide has been on it for 1.5 years now. Yeah,
Oh, wow.
and I really don't, So, but this is not routine. So I'll do it when I have a high index of suspicion.
Yes.
I'm more inclined to do these tests when I have a treatment for these patients, rather than just make it look all glamorous and say, yes, you have a positive androgen receptor. Then what happens?
Right.
So the ambiguity on the cutoff on the percentage of positivity is huge with AR. But if you got an 80 or 90%, I think it becomes simpler.
Yeah.
So another question in the chat box is, so what is, in your experience, your response to FEC plus zoledronic acid in upfront metastatic bone lesions triple negative? So I think they're looking at response rates to chemotherapy, multi-agent chemotherapy in the first line setting triple negative breast cancer. So
if the patient has bone only metastasis, I'm quite comfortable giving anthracyclines and alkylating agents in triple negative disease. I mean, I do start off with a taxane, but then my second fallback is anthra, and then I go to eribulin or capecitabine or whatever. But I think anthracyclines are a good drug for triple negative. There's nothing wrong with using that.
So let me ask you this question. So for a de novo metastatic triple negative breast cancer, would you be tempted to use a combination all the time, or are there occasions where you're happy with just a single agent?
It depends how symptomatic the patient is, because you will get this profile only with bone and nodes and a small lump in the breast. They're rare, but you get them. And they're elderly patients, and they're certainly not going to take a full combination. I sometimes do even oral CMF for these older patients.
Right.
So, yeah, you have to go by the clinical picture and not get frightened of this triple negative business all the time.
Fair to some extent. So to something similar to ER/PR positive, right? So
yeah,
you use a combination only when you have to.
Absolutely. I'm comfortable with monotherapy. Yeah.
So what is your take on metronomics for TNBCs?
So there are a lot of places that are doing it. Some places that are giving it adjuvant for a year or two. I tried it on a few patients. They got terrible mucositis and bone marrow suppression and came back to me and said, "Pehle itna chemotherapy diya, neuropathy karaya, abhi muh jala hai, take it back." So that was out. So oral metronomic was out in that setting. Yes, I am using capecitabine. So I am using capecitabine after explaining that you will have black hands and feet for 6 months or a year or whatever. This is the benefit. There is an OS benefit. If you're young, if you haven't achieved a PAT CR, I think there is absolutely no harm. So I do it.
Great.
So there's another question. I think we've already answered that, but I'll just take it up again. So what is the choice of treatment? You adjuvant followed by surgery or upfront surgery for a triple negative that's T1 or 1 centimeter. I think you've answered that. Dr. Geeta, do you have a different answer to this?
So, you have to decide what is your cutoff, 2 centimeters or 3 centimeters. Because, if it's a 2.1, I'm not sending them to you in any case. So sometimes what I do is when I see a 2.2, 2.1 centimeter tumor, sometimes don't do the ER/PR HER2 at all, because I don't want to answer this question.
In our setting, it's perfect. But I'm telling you, abroad, they see, first of all, it's all screen detected, Geeta. So very few are coming with palpable tumors. The most they can hope for a neoadjuvant is 1 centimeter. And they get 1 centimeter, they start giving neoadjuvant chemo. I'm like, what's the fun? The fun is in seeing the big tumor go down.
So then your PAT CR premise also goes for a toss, because 1 centimeter is very likely to have a PCR.
Correct.
And they will do well in any case, whether you got a PCR or you didn't get a PCR.
So there's data to show that in larger tumors, compared to smaller tumors, there's a lower chance of getting a PAT CR. I mean, that's a given. So then we are comparing apples and oranges here, really. We are not comparing fairly.
Right. So I'll continue to operate my 2 centimeters and 3 centimeters.
The next 1 centimeter you get, you give neoadjuvant and then centimeter.
And then you don't put in a clip also.
So clip has to be done right.
So
Absolutely.
in triple negatives, if I'm sending for chemo, I would put the clip up front.
Right.
Unlike in your ER/PR positives, where you can wait for
Correct.
possibly 2 cycles and then put in a clip.
Because some things they respond very quickly, especially
Very
if you
quickly.
put vaccine up front.
Very good.
So, the discussion on the platinum usage in neoadjuvant setting was excellent. Now, in a real world setting, we often have these patients who are clinically T1 or T2 node negative, but then turn out node positive in the histopathology report. Now, I do know that there's not a lot of data, or correct me if I'm wrong. So, would you be tempted to add carboplatin in a adjuvant setting, especially for a heavy node burden, young triple negative breast cancer, BRCA negative? Would you do that, or would you just stick to a dose dense AZT?
I just prefer dose 10 AZT. Honestly. I don't have that.
Yeah, there's hardly any data.
Yeah, and I'm keeping it for later. I've got to keep everything for later. I know she's node positive. And I know there's a high likelihood that she's going to relapse. So I'm going to have first line, second line all sorted in my head. And it's sad because that's the way it goes. So many of them come back to kids. So you've got to keep it all. And if she can do PD-L1 testing and take great. But if she can't, and most often they can't, all of them take it. Platinum is a good option. Did I answer all the quiz questions?
Yes,
madam,
the quiz answers.
We are going to the quiz actually. So I think the reason why there were a little fewer questions today was because the encyclopedia of knowledge that you gave today. Thank God we were recording this thing, because then we need to go back again and see what you have told us. There's so much information in those 30 minutes that.
Yes, Baba.
Madam, not 30 minutes, 40, 45
1
minutes.
hour.
Yeah, 1 hour.
1 hour.
1 hour almost. So my clock shows almost 1 hour 10 minutes. So it's just that it's actually an encyclopedia of TNBC. I'm so happy that we had this thing. So we are going to the quiz answers, and I think most of the questions have been answered in this thing. Sorry, just give me a minute. I'll screen share. You want to?
Before everybody could join in, so we had about 22 people at the start of the quiz. So there were
Really?
it was 3 questions right. I'll just read out who that is. The one who got.
I think, and in the range that reduction controversial, and the data is not a lot. I think 300 have talked about 10 to 15% positivity in triple negative breast. This question, I think both the answers
9%.
So I think this data varies a lot. I think the PAT-CR question, next question, I think we are looking at predominantly PAT-CR for platinums.
Correct.
Controversy regarding the endpoint and the results from this is the keynote 3.5 as yet. We just have the PFS data. And I think the predominant benefit has been CPS greater than 10. I think we would be keenly following the OS data. This study looked at combinations other than taxane. So this also looked at gemcitabine and carboplatin combination. So probably closer to contemporary real-world practice as compared to the IM passion, which just used nab-paclitaxel along with the immunotherapy drug atezolizumab. And the last one, I think probably this was the easiest one. So I didn't put in any figures. I think this is a very exciting drug, as Sam was saying. Very, very promising data in terms of PFS. We are looking at very